benefit from regional node irradiation in terms of absolute reductions in both recurrence and mortality in post-mastectomy breast cancer patients, in particular including those with even less than or equal to 3 positive nodes. More recently, there are several studies that show benefits from regional lymph node irradiation in patients who underwent breast conserving surgery. Those results aren't published, but all right, sorry, a little technical difficulty. So while this topic remains sort of hotly debated within the radiation oncology community, there does seem to be a trend towards more frequent inclusion of regional node irradiation in breast wall, which a lot of us have been doing, but also in breast radiotherapy. So the objective of this presentation is to discuss the fundamentals of breast treatment planning, focusing particularly on regional node irradiation. And I'm going to spend most of the time talking about beam design, because I think in general if your beams are correctly designed, the rest of the treatment planning is more straightforward. And then also methods to reduce lung and heart dose, and that's actually where I'm going to start. So for our left-sided breast and chest wall cases, the main technique that we use to minimize dose to the heart is the deep inspiration breath hold technique. And so there's many ways to accomplish this. There's the ABC active breathing control, and there's also self-help breath hold techniques, either with or without respiratory monitoring, or with respiratory monitoring as well as feedback guidance. And so since this is a planning talk, I'm not going to talk too much about the details of how we do our DIBH technique, but in the handouts that go with this presentation, I have about 10 slides that go into detail in terms of how we do this at our institution. But in general, we treat about 1,000 breast cancer patients per year at MD Anderson at our main campus, and we implemented DIBH about 10 years ago in 2004. And we use it on almost all of our left-sided breast cancer patients, so between 90 and 95% of the patients. We also use it in a small percentage of our right-sided breast cancer patients, so about 3 to 5% of those cases. For our left-sided patients, the only time we don't use it is for patients who really can't hold their breath or cannot breathe reproducibly. All right, so this is a slide showing you what we see on a typical patient in terms of heart displacement. The gray image is the free breathing, and the orange image is the free breathing, and the gray is the DIBH. And you can see that the heart is displaced posteriorly, inferiorly, and to the right. And so in most patients, this change is actually quite significant. This is an image from the literature showing you tangential beams on a DRR. And so you can see on the top image, the free breathing, there's quite a significant amount of heart in the field, whereas in the bottom image, in the DIBH, there's much less heart in the field. And so this translates to better dose volume parameters for the heart. These are some data that show essentially how much dose the heart is getting. These are for our patients, about 120 tangent patients and about 150 tangent superclav and IMC patients. And so, is there a laser pointer? If you move it up. Ah, there we go, sorry about that. You can see that the mean dose for tangents only is about 0.6 gray and about 3.5 gray for the patients that have the comprehensive treatment. This is typical of what we see in our patients. These were consecutively sampled, and they're from patients who were treated in 2013. And you can similarly see that the V4 doses are also pretty low. All right, so what about the lung volume changes during deep inspiration breath hold? So air is drawn into the lung and the thoracic cavity, the volume in the lung actually increases. And so this translates to the percent lung volume receiving particular doses being lower compared to the free breathing. And so this has been observed in the literature. And then with some of the data from our clinic, we don't have too much data for patients who are in free breathe because we don't treat that way, but I compared the left-sided and right-sided cases. So right-sided 100 cases in free breathe and 130 cases in breath hold. And you can see the major differences in the lung volume from 4,000 cc's to 2,600 cc's. And then if we look at the corresponding changes in the dose parameters, So 4.75 versus 6.1 for the mean dose, and similar changes in the V13 and the V20. All right, so I'm going to try and get the SAMS questions out of the way early. All right, during deep inspiration, the heart position shifts in which direction compared to free breathing? Oh. All right. Okay. Okay, I'll do that on the next one. Okay, and so everybody got that right? Well, most of you. And then here's the slide showing the correct answer that I just spoke about. All right, so the next one, the expected change in the lung volume, the V20, for a patient whose CT scan was acquired in the DIBH mode is expected to blank compared to a scan acquired during the free breathing mode. And so would the dose be higher, lower, or no difference? Okay. This one was, it's very hard to think of these SAMS questions. Well, because you also have to have exact citations, right? I think that's what makes it hard. Okay. And here's the correct answer, and I followed the rules, and I've put a citation for this answer in here. All right, so now I'm going to talk about field design, specifically for regional node irradiation. So what you'll notice is that I'm going to sort of jump into patients getting tangents and IMCs, and I'm skipping over tangents only. I did include about 15 slides in the handouts that sort of go over the specific details for that. Okay. So there's many different ways to do a comprehensive breast treatment, and by comprehensive, I'm referring to a patient who will have tangents, medial lateral, plus a superclav, plus an IMC field. And so what I'm going to focus on is a multi-isocentric technique for the 4-field CRT, as shown here in this figure. All right. So the basic guidelines for creating tangents for a patient who's having the comprehensive treatment is very similar to designing a regular tangent, with the key difference being that the gantry angle is going to be steeper to accommodate the IMC field. And I think sort of the most important thing when you're selecting the angle is sort of picking that break point where you're going to junction the IMC and the tangent field. And in every patient, this is going to be different and very much anatomy specific. So you want to have the thickest part of the breast tissue and the part with the most variable thickness within the tangent. And then you don't want to have a highly variable thickness across the IMC field, because the energy of the electron is very much dependent on depth. All right, so this is an example of a patient who has a rather medial breast with a sort of large slope here. And if I'm thinking about where I want to put the angle of the IMC field, if I start, okay, all right, so if I have an angle like this, right, so my IMC field that I would need to create would be too narrow to achieve electronic equilibrium, and also I would have a lot of lung in my tangent field. If I did an angle more like this, this would result in wide variation in tissue thickness of the IMC. So if my tangent ended here, my IMC field would go across this sort of thick part of breast tissue. So sort of as a compromise, I would put it here and have a moderate amount of lung, not too much variation in thickness across my IMC field, and most of the breast tissue encompassed within the tangent beam. All right, so what about energy modulation? So at our institution, we primarily use field-in-field technique for the modulation of the tangent beams. And then these are some of our general rules for energy selection. So if the patient separation, and this is the majority of the patients, is less than 23 centimeters, we use 6 MV for our open fields and 18 for our field-in-field. And we will occasionally do some splitting of energy on the primary open beam and do an open 18 beam as well. For our larger patients, greater than 23 centimeters, We use 18 MV photons for the primary open field and then 6 MV for our field and field. And really we just select the energy that gives us the best possible plan for an individual patient. All right, so when do we use wedges? Well, this is an example of a patient. This shows you the tangent fields, and then there's an IMC matched right here. And so you notice that this patient has a very sort of steeply peaked breast. So this is a case where we'd use wedges, or where the tumor bed is very deep and close to the muscle. So we sort of want to push the dose to that location. Also, we use the step and shoot technique for field and field, so we try to keep the number of fields low. So if we have a lot of, and it's usually in these steeply peaked breasts that we would need a lot of field and field, we'll use the wedge as an alternate. All right, some guidelines for the energy, or for the beam angle. So you want your IMC beam to be as close to en face as possible, but at the same time you have to think about that cold triangle between the junction point of the tangent beam and the IMC. So generally for an intact breast you'd have an angle somewhere between 15 and 25 degrees, but occasionally you might use 30 or 35 degrees. So the IMC field, we try to keep them at least 4 cm wide. Ideally it would be 5 cm, but sometimes you have that steeply across the IMC field that the tissue thickness is changing so much that we will use 4 centimeters. And we try to use the lowest possible energy, and I'll come back to energy discussion in just a minute. All right, so this is a slide is showing you sort of what you want to think about at your junction point. And so generally the hinge angle between the IMC and the tangent beam is between 10 and 15 degrees. If it's too small, the plan gets really hot, as shown here on the left panel. So the angle between the tangent and the IMC is 7, and it's nearly parallel. And so when you run the dose calculation for this, it's just going to be really, really hot. If, on the other hand, you use something larger, like 17 or 18 degrees in this example, you can see this cold triangle is right in this breast tissue above the pectoralis muscle, and it would be too cold. And so as a nice compromise, 12 degrees works really well for this particular patient. All right, so what about junctioning then? In general, you don't want to junction it over the tumor bed because that's where your cold spot's going to be. But this can be an issue when you have a tumor bed that's very medial and close to your IMC fields. So if you look at this anatomy, right here in red is the patient's tumor bed contour, and here in blue is the IMC vessel. So they're really close, and there's really no sort of ideal compromise for this. So one thing you can consider is to use a 3 millimeter overlap. So that's shown here. You can't see it that well, but there's a 3 millimeter overlap between the IMC field, which was actually split into 2 different energies, which I'll talk about in just a minute. But how hot does that make the plan? So this patient is a 50 gray patient, so the Dmax is 70 gray. But then when we evaluate it, we look at sort of like the 65 gray isodose line and how many cc's does that encompass. So for this patient, it's about 1.5 centimeters and about 25 centimeters for the 60 gray line. So we consider this acceptable because tumor coverage is our primary goal. So what about, you might be asking, well, why not just wide tangents? So for this patient, she really has sort of suboptimal anatomy for wide tangents. She's very barrel-chested, and if you imagine crossing a tangent all the way across here to cover all of that tissue, you'd have a really high lung dose. So we did not select wide tangents in this case for that reason. So what about junction dosimetry and SSD dependent? So in this case, I've just shown a couple of isodose lines, but this would be the tangent beam, and then over here is a wider IMC field. And so I'm showing you the 90% isodose line, and you can see that that's breaking up right here at the junction region, and this cold region where the 90% is not covering is on the electron side of the field. And then this 120% hotspot is on the photon side of the field. And so this is what you pretty much always see, and this is caused by the outscattering of the electrons. And this becomes worse if you use very large SSDs, such as 110, for example, which we almost never use more than 107, but just kind of depends on clearance issues for individual patients. So this is an example with 110, and you can see the 120% isodose line gets much larger, and then this, it's a little bit hard to see, but the cold region right in here is a little bit larger on that electron side of the field. All right, so a few more things about energy selection for the IMC field. The energy is going to really be based on the coverage of your nodal areas and your breast tissue. So you want the IMC vessels, or at least in our institution, our guideline is IMC vessels levels 1, 2, and 3 should be covered by the 90% isodose line. And then beyond that 90% isodose line, in the lower portion of the IMC field, we like to see the 90% line cover to the pectoralis muscle. And if there's breast tissue involved, then the breast tissue in the lower portion covered by a higher line. Generally, we achieve this with electrons between 6 MeV and 20 MeV. And for most patients, it's at least 7 MeV. So in some patients, as you go superior to inferiorly, the tissue is going to vary, the thickness is going to vary quite a bit. And so this is really ideal for sort of splitting the IMC into an upper and lower component, where the upper component has a higher energy and the lower component has the lower energy. And this is particularly advantageous because in the lower portion, you're passing through the major components of the heart, and so you can reduce that heart dose by splitting these. A few more things about energy selection. So patients who have really deep IMC vessels often will require high energies, such as 16 or 20 MeV, and this leads to really high skin dose. So the way we deal with this is to do photon-electron mixing. There's a couple of different ways to do this, and it's going to really depend on the patient's anatomy again. So here in figure A, this is a beam that was weighted 4 to 1, where the photon and electron field have the exact same dimensions. And so treat 4 days with photons, 1 day with electrons. And here in panel B, the thicker portion just spanned a very small section, so that's an 18 MeV photon supplement just through a portion of the field. So you get 50 gray from the upper IMC, and then somewhere between 4 and 8 gray, so between 8 and maybe 20 to 25 centigray per fraction for that small IMC photon supplement. All right, so who has good anatomy for tangents in IMC? So what kind of case do I get really excited when I see the CT scan and I think this is going to be easy? Right? So this is sort of an ideal case. So the breast tissue is very medial. This center portion along the chest wall is reasonably flat. So in this case, her thickness in this region for the IMC field, and now I'm going all the way to this IMC when I'm looking at the depth, right? So that's between 3 and 3.5 centimeters. So that's really not that much variation. And also, I didn't show this here, but the tumor bed is actually also very far from the junction point. So all of these things make nice for tangents in IMC field. And so this is really easily covered by your sort of standard fields. This is that same patient, but now we're a couple of slices more inferior. And so now we're in the part of the IMC field where I've passed level 3 vessels, and so now I just need that dose to come to the pectoralis muscle, and so that thickness is 2 to 2.3 centimeters, much thinner. So in this case, I can use a lower energy electron and split that here and get a lower energy electron exiting through the main part of the heart. All right, so what kind of anatomy makes me cringe or makes me they're very difficult to plan, and this would be the exact kind of case. So this patient has breast tissue that's very medial rather than lateral. The tumor bed is not close, but near the junction region, and then also there's this really steep angle of her anatomy where I'm trying to fit that electron IMC field and get in that en face angle. So the general solution is less angling of the tangent field. So in the case where the tissue's more lateral, you'll have a very steep IMC angle, as in the previous example. And in this one, you're going to have more of a shallow angle. But then conversely, the IMC field is going to have a bigger angle. And so these plans tend to get a little bit hotter. So why not partially wide tangents again? This is a patient I already showed you. She's somewhat barrel-chested, and again, we'd get a really high lung dose. All right, so overall, this is what this plan looked like. So it was medial lateral tangents, mixed, open, and 17% and 27%, 18 and 6, and then field and field components. Superclav was weighted 1 to 1, 6 and 18 MV. And then she had a upper IMC for 50 gray, 12 MeV, a lower IMC for 9 MeV, and an 18 MeV photon supplement that was the same dimensions as the electron IMC field. All right, so what do these isodose distributions look like? So this patient had also, in addition to sort of a steep slope here, she had very deep IMC vessels that were just over 5 centimeters. And so in that case, you would have wanted a really high energy like 20 MeV. So that's not so ideal. So what we did is, as I mentioned, mix the 12 MeV and the 18 MeV. And you can see, it's hard to see the IMC vessels because the isodose lines are covering it up, but that 90% isodose line comes down and fully covers that. As I said, these kind of plans can get hot, and we had some clearance issues with where her arm was positioned, and so the SSD was 107 centimeters. So you'll notice the hot spot's kind of hot, but the 65 gray isodose line is about 3 centimeters, and then the 10% isodose line is about 120 cc's. Her V4 for her heart was 20%, her V20 was less than 1%. Also, her V20 for her lungs was very reasonable at 16%. All right, last Sam's question for the session. All right, so at the junction of a photon tangent beam and an electron IMC beam, the hotspot will be on the blank side of the junction and will blank with increasing electron beam energy, electron beam SSD. Oh, it's too late. think really, really fast. Oh, you all think fast really, really good. So it's on the photon side and it increases. Oh, or it was just an easy question. All right, so as I'm supposed to do, I cited a reference from this. Everybody knows this figure from the context book with a photon field matched to an electron field, the bigger SSD, the bigger hotspot. All right, so I didn't want to not discuss partially wide tangents because occasionally, well, I wouldn't say occasionally, in some situations they're a good solution for specific anatomy. And so when are they a good solution? So anatomically, it's a better option for patients where the breast tissue is more medial, as I showed you in that one example. But there's also a couple of counterindications when, even when the breast tissue is medial, where you wouldn't want to use this solution. So it's really, if you also have the contralateral breast being very medial, then when you try and do the wide tangent, that very shallow angles crossing over into the contralateral breast. And then again, patients who are very barrel-chested, where the chest wall is very curved. When you use that very shallow angle to cover the IMC fields, you end up with a lot of lung in the field. So now I'm going to show you an example of somebody who we did partially wide tangents on and had a nice result because she had nice anatomy. And so the chest wall doesn't have a huge curve here on the lung. This is a superior slice, and you can see the tangent beams do include a lot of lung in this portion of the field, but that's because we've got to get coverage for the IMC vessels. But then in the more inferior portions of the field, you can see now that you have much less lung. And so you can see this is sort of the open field here in this panel, and you can see we've got the blocks drawn in here to shield as much lung as possible and still have margins on those IMC vessels. And then these are the subfields that were used for this patient, for the medial tangent. And this is what the isodose distributions look like. So the V50 for both the tumor bed and the IMC vessels was 98%, so good coverage. And then the overall hotspot, which was about in the middle of the breast right here and close to the tumor bed, was 62 gray. And you can also see here, this is the IMC, right behind this little 5% hotspot is the IMC vessel. All right, so what's different when we do chest wall irradiation and regional lymph nodes for a chest wall case as opposed to an intact breast? And so in general, the field design is very similar, but the key difference is that the angle of the IMC field is often going to be smaller. So you might use 10 or 15 degrees and occasionally 20 degrees. And that's just because the patient's surface tends to be very flat in these patients, and because their surface is flat, you don't need as much angle to be en face. A couple of other caveats: you want to cover the entire volume of the mastectomy flaps, and if the patient has T4 disease, we routinely cover the drain sites as well as overlapping all of the junctions 3 to 5 millimeters. All right, so this is an example of a chest wall case, and I just kind of drawn this line here so you can sort of really see at a distance how nice and flat her surface is. Her IMC vessels are pretty shallow here, and then this is the chest wall tissue that we're covering in the tangent beam. So you can see this has less angle here, and then there's a small cold triangle right in here. And then just to remind you for comparison, this was a patient who had a very steeply sloping breast, and you can kind of just see the difference between the angle of the two IMC fields. And that's kind of all I'm going to say about that, because I did want to mention one other clinical scenario that we see a lot. So in general, that match line, which I didn't talk too much about, but that match line, we're using a patient's axial slice to get that straight, non-divergent match. And so there's times where having an angled match line would really be advantageous. And so those of you who are a little bit older in the room might remember the rod and chain technique. We actually still use it at our institution. But maybe a little more high-tech version of that is the virtual rod and chain technique. So I'll first talk about when you might want to use it, and then how you can use it without actually using a rod and chain. All right, so the first example of where you would want to do this is where you want to treat high tangents. And so this would be a patient where you have a low axilla that you want included within the tangents. And so this patient, you can tell she has her arm really nicely elevated, and so that's quite helpful. But if you imagine if we had a straight border, if I put the straight border here, it would be too low, and I wouldn't get all of the axilla in the field. And if I put it up here, it would be very high. It would have a lot of lung in the field, but it also would start to go into her armpit, which can lead to some unpleasant skin reactions. So by using this rod and chain at an angle, we're able to achieve that nice match line and get the entire axilla within the field. Another example where a straight border is suboptimal is those patients who really can't raise their arm because of pain or previous injuries. Or patients, sometimes down here in the arm you'll see some sagging tissue that comes into the field. And so the solution is often to tape the skin, which is very uncomfortable for patients. So a rod and chain is a nice alternative to doing something like that. All right, so what does the beam design look like for rod and chain to get that non-divergent border? So on your axial images, you'll actually go through and contour the rod and chain where you can visually see it. And then this is a tangent beam where I've rotated the gantry, but my couch is still at 0. So the next step, you would come in and you would rotate the couch until the rod and chain contours align with each other perfectly. But then now if you look, now I've got a lot of lung in the field. My collimator is not following nicely along the chest wall. So then I'd come in and tweak the rotation of the collimator. And so now my collimator is rotated so that it's nicely following along the chest wall. You can see the rod and chain here is nice and straight. And then the last thing I would do is I would come in and draw a block. I would come in and draw a block here and actually block out this portion which is shown here. It's a little bit hard to see, but you can see there's a block drawn in there. And then I would convert those to MLC once I'd drawn the nice straight block. All right, so not everyone wants to use a rod and chain. They're a little bit uncomfortable. A lot of places feel like it's very old school. So how can you do this without actually doing it? So you can create a virtual rod and chain. And so the way that we do this is we actually start by setting up our superclav field. Even if we're not going to treat a superclav field, I'll create a fake superclav field and delete it later. But so you're going to rotate your gantry like you normally would to 15 or 20 degrees. And then you'll rotate the collimator. So normally in the multi-isocentric technique, the collimator is at 0 for the supraclavicular field. But for a virtual rod and chain case, you're going to want to rotate that collimator. And you're really going to look at the 3D image, and you're just going to rotate it until you can see that that's not, the tangent fields wouldn't be crossing through the arm, or that they're covering that axilla field. So then you just start making your fake contours. You draw a small circle for the rod at the skin surface on the first slice where you can see the superclav. And I've sort of cartooned this up so you can sort of see it at a distance. All right. Then you just sort of try to visually hold your cursor in the same spot and go down inferiorly, slice by slice, and draw your little circles. And you can see they start to sort of end up following an air, kind of the way a real rod would if it was laying on the patient's skin surface. And then the last step is once you're completely out of the patient's CT scan, you just drop a rod contour down there, something like that. And then when you look at the DRR images, and you're going to, again, just like you would with a real rod and chain, you're going to rotate the couch until those two contours align along each other. So once you have the contours drawn, it really looks almost the same. And so this basically just shows you what you would see. You would see little dots along here. And then on your DRR, you would draw your tangent border to match that on your DRR of your tangent. I think I'm going to be kind of ahead on time. I might go into some of my extra slides. So my sort of concluding remarks were that every breast case is unique, even though all I do is breast cancer cases. Every single week I see some anatomy that sort of confounds me onto what our solution is going to be and how we're going to come up with the best possible plan. So I would say everything I've talked about are sort of generalizations, but for each patient, you're going to have very unique types of solutions. And some acknowledgments. So these are the physicists on the breast service at MD Anderson, my colleagues who I work with. And in particular, my service chief, Mohammed Salahpour, he looked over all of my slides and for about the last 3 months has been kicking around ideas with me as to what I should put in my slides. Joe's son, Adam Mellon's son, Kent Gifford, and I'm not so good at saying Dr. Morgan's name, so we usually just call him Morgan. And then these are our breast radiation oncologists, and in particular, Ben Smith was really helpful. We had some discussions that in terms of picking out patients with good anatomy and bad anatomy, and he helped me pick some of the slides I showed. And then these are our dosimetrists that do breast and GU. And I have a whole lot of references. Should I?
I got questions.
Take questions?
Yeah.
Okay. So that concludes my talk. I'm a little early, so I'm happy to answer questions.
All right. Well, I got a question if you guys don't. On your breath hold,